Yeah, no pressure at all with that, right? So, but you know, I was really happy that this conference is a telehealth conference and not a telemedicine conference, because what I'd like to do is expand your thinking a little bit around all of the usefulness of telehealth and how it is getting reimbursed, and I'm going to share a couple of models for that. But you know, people don't spend very much time with their physician, whether that's in person or on a telemedicine platform. But what thousands of doctors do every day is tell their patients, lose a few pounds, exercise more, eat better, sleep better, and then send them out into a world where that's not very easy. And so what we looked at is, what is the opportunity to create a network that is keeping people compliant with their care plan or preventing chronic disease between episodes of clinical care, and what are all of the ways that those programs could be delivered and then get paid for by the health plan. So Solera is focused on non-medical primary prevention, so that's chronic disease prevention, cardiometabolic risk reduction, but secondary prevention, right? How do we prevent the sequelae of disease? Emotional well-being, so sleep and stress, and not even clinical behavioral health, but just sort of, I call it life sucks disease, and then social supports, right? Sometimes I feel like we're treating the trailing indicators around obesity and chronic disease when really we should talk about food insecurity, air conditioners, housing, and emotional well-being. And so how do we pay for those things? And so, you know, we looked at the literature and said there was tremendous amount of evidence for the impact and return on investment for these types of services, and yet they never scaled. And I'll talk a little bit about the diabetes prevention program. I think it's a great use case and certainly something Fruit Street and Julia's here with LARC in our network. You know, they have the ability to make a huge difference. And for those of you who don't know, this will be a required Medicare benefit for all Medicare beneficiaries next year. But we looked at it and said, wow, there's only been 35,000 people, over 86 million eligible people who were ever referred to the program. And so why was that? And we purpose-built a business model to solve all of the barriers for you, you know, if you're a physician, to say, okay, I know my patient could benefit from one of these resources when I send them out into the world where it's not very easy, but I don't know how to get them in those programs. I don't know if those are good quality programs. I don't even know what program would be best for my patient. And so, you know, we looked at it and said, you know, where the money flows is with a payer, with a health plan. So in our model, 100% of our contracts are with health plans and 100% of our revenue is through medical claims based on pay-per-performance. And so when we go to the health plans, we said, gosh, you have a really diverse member population. So how could you or the physician ever possibly pick the best program? And frankly, there are thousands of them. I mean, we've got telemedicine folks in the room, but there's digital, virtual, telephonic, do it on your phone, you name it, community, thousands of different types of programs delivered in different places. And there's been a lot of focus on consumer engagement, and we believe that consumer choice drives engagement and outcomes. Why should a health plan pick a point solution? Why should an employer pick a point solution? Let's let the person pick how they want to participate based on their unique needs and preferences. They'll tell you what they want. Do they want to go to a YMCA or a Jewish community center or their grocery store or their doctor, or do they want a telehealth platform or digital? And I think the other fallacy is, why are we asking them either or? I say this all the time. Why are you saying, do you want community or digital? We should be asking them how much you want when you want it, and it really is a sliding scale. I always say, just because somebody decides to participate in a telehealth session with a physician doesn't mean they never want to see a live physician, right? And so it's, how do we provide the services that they need at the time the patient actually needs it? But it has to be easy, and I'm going to talk a little bit about our model. So this is what we do. We contract with health plans. We have 70 million covered lives for the diabetes prevention program. We're contracted for over half the Medicare Advantage lives. And so we have a huge amount of coverage, but we don't do any programs and services. We have developed an integrated network of program providers getting paid through medical claims for providing services. And so, but when we looked on the consumer side, we have to make it really easy. We can't give them a mall. We can't allow the patient to switch or choose. When we looked at the barriers to the diabetes prevention program and the initial studies with the Y of the USA, they had 16% enrollment when a physician identified somebody at risk, and they gave them a list of local places to go, and they said, here, I want you to participate in this program. It's a great program for you. Go sign up. 16%. And you know, I always said in the analogy, it's almost like handing a patient a list of statins and saying, pick which one you want and call your pharmacist and get a prescription. There were so many barriers to getting people to actually enroll, nobody did. And so we said, how do we create this look more like Match.com, right? Where a doctor just has to say, go to a website, make sure your health plan is paying for this, and we'll find the best program for you by asking you what your needs and preferences actually are, and I'll take you through that. So basically, we've created a many-to-many marketplace in healthcare that I don't think existed before. We're only about 22 months old as a company, and again, we've enrolled more people in the last 6 months than the entire DPP industry in the last 4 years. So we've solved for something around the barrier, but Solera is the contracted entity with a health plan as the delegate. We function as the health plan, but what we allow the payer to do is use a non-medical resource. So we can contract with somebody who has no licensure, clinical credential, or certification at all to deliver a service provided through a health plan reimbursement. And I think this is really revolutionary because there's a lot of things that don't have to happen in a doctor's office. There's certainly lots of things that need a clinical chaperone that we would love for a physician to plug into this, because with our model, the health plan doesn't care that it's on your phone or via telehealth. We eliminate the regulation around allowing telehealth to be paid for by claims, because the payer is paying for a service. They're paying for a CPT code to deliver a service regardless of how that service is actually delivered. So we're the single point of contracting and revenue cycle management with the payer. We have a broad network of network partners. We're completely open. It's not a pay to play. It's just be in our network. You need to meet our compliance. You have to have some evidence that you work. You need to be able to scale. And then we do net promoter scores and benchmark performance of quality across our network every week. So my commitment to the payer is a high-performing network, because I don't get paid unless our network partners do well. It's all pay per performance based on people doing well, meeting engagement, and ultimately outcomes and programs. So this is what we do. We're HIPAA secure. We do all the due diligence on our partners. We actively build a network, because our network is not only digital and virtual, telehealth, et cetera, it's also in-person community. So places like Jewish community centers and even DaVita dialysis centers are in our network, providing prevention around diabetes. Grocery stores, churches, Weight Watchers, Jenny Craig, they're all in our network. And then we match people. And I think that's really sort of interesting around the opportunity to ask people what they want. And then if they pick something and it doesn't work for them, we let them switch, not just drop out, but let's find you something that really works for you, do all the revenue cycle management, and then actually do all the quality management and roll-up reporting. And again, we get paid on performance. So we get paid when someone enrolls in a program, we pay our partner. We get paid for the diabetes prevention program when somebody is still engaged at week 4, we submit a claim, we pay our partner. It's almost a cash business because we get paid out of claims in about 7 days, and we write checks every Friday. And so we've created an ecosystem where people can get paid. Blue Shield California came to us. We cover all their commercial members for both Blue Shield California and Anthem California. So for diabetes prevention, we have 13 million covered lives. We're contracting with Kaiser. Medicaid, the Deep Diabetes Prevention Program, will be a covered Medicaid benefit. So you will almost have ubiquitous coverage for DPP in California next year. And I think what's exciting about that is it provides a lot of opportunity for different types of payers to do that. But again, just get them to us, get them to soleraforme.com and let people actually enroll. So we are a single source solution connecting patients to an integrated network of community and digital providers around prevention, coping, and support. We started with DPP, huge market. We had a line of sight people were going to pay for it, and the CDC said these folks were good, because we didn't think when we initially developed this market that the physicians and the payers would believe me that I curated a network. But now that we're benchmarking performance and we're doing net promoter scores, they're trusting us to say, yes, what else can you do? So Blue Shield California came to us and they said, you know, I really want to try this cardiac rehab app or this pediatric asthma app, but I don't want to contract with them. That takes me 18 months, and I have a BAA with Cedars-Sinai. I can pull in Cedars-Sinai data. We outreach on the doctor's letterhead. I say, Dr. Jones wants you to do this program because it's really great for you. Dr. Jones didn't see that patient, because in 15 minutes, you're not thinking about prevention. You're thinking about treatment. But the physicians are more than happy for us to try to engage their patients in these programs as long as we report back what is actually happening. Is Mrs. Jones working through the program? And if she's not, call my care coordinator and see if we can get her back in. So we take that burden off of the physician. And so this is a snapshot of our network. It literally changes all of the time. So Fruit Street is a telehealth. Julie is going to talk a little bit later around LARC. We have U.S. Preventative Medicine is telephonic. But I also think there's a huge opportunity for the telehealth industry to be an adjunct to some of the other community providers like grocery stores. So Albertsons and Kroger and others have dietitians. They could absolutely be supplemented by a telehealth platform that even has a physician for those patients who have comorbid conditions that want to talk to a doctor as a part of these prevention programs. And so, then we also talk about network access. Medicare is only going to pay for in-person community providers. Our current networks on the left, our network in 1-1 will be on the right. We don't have ubiquitous coverage. So from a network access perspective, we have proposed to CMS that if a patient doesn't have access to a community provider within a certain number of miles, let's get them to a telehealth program like a Fruit Street that's actually recreating that community and in-person environment. In California, again, we've enrolled well over 10,000 people in diabetes prevention just this year, and then have a large network. But you can see there's some places in the Central Valley where there are not community-based programs. The next market we're integrating is mental well-being and stress and resilience. They don't have to go through this, but it's a big problem. And certainly the literature shows that there's a direct correlation between obesity and sleep and stress and chronic disease. So we think people may need to do those things before they're ready to make changes around nutrition and physical activity, or maybe they do them together. But when we looked at this market, what was really interesting is that there's a ton of different types of programs in the mental well-being space where we can actually do a better job of matching. And when we look at our matching logic, again, it's not a mall. We're like Match.com. So we're asking people, do you want more of a cognitive behavioral therapy style or a meditation style? And we don't ask it that way. But do you want to explore? Or do you want a structured program? Do you want a coach or no coach? Do you need some type of asynchronous learning, or do you like synchronous learning? Do you want independent or group? And if we ask them those questions, they will pick the program that's best for them, and they do really well. And what's fascinating is people say, my program is better than another program. What our data shows is that if we allow the person to pick, people do well, and they do equally well because they were able to pick the program. Let's let consumers decide. Because as soon as we treat them like consumers and we don't treat them like patients, they will engage in their health. So I'm going to take you just really quickly through the consumer experience. These things you can tell are branded for Anthem. We outreach in a variety of ways to get people engaged. They go to a website, we can private label this, and we say, hey, this new benefit is available to you, see if you're at risk. If they're at risk, we give them a message and we say, let's get started. The let's get started is that matching, and we make it really fun, kind of like, ooh, see who we're going to match you with. If they go through the process, 75% of those people will enroll because we just gave them the option of which they told us they wanted. If they pick a community location, we look sort of like when you're searching for something on Yelp, we bring up the available programs, the days, the time, the language, and then we match them with a program. At that point, the relationship between that consumer or patient is with that program provider, and we just became the data integration and data warehouse to do all of the claims management and roll-up reporting. And what's interesting about our data is it's largely driven, what people are choosing is largely driven by age. So just to orient you, the orange is digital and virtual, the red is Weight Watchers, and the green is community. And again, this is about 6,000 people. This is specifically for the diabetes prevention program. But you can see on the right, the amount of engagement and ultimately weight loss that we're seeing from these participants far exceeds the averages that we've seen published certainly in the literature around enrollment and then also outcomes. And then again, we are the centralized database for all of the data. So everybody in our world gets a cellular scale and a Fitbit Flex. We're getting sleep and physical activity data. But we are actually documenting performance every week. So you can see, you probably can't see, but this is a list of our different program partners. And we are really transparent with the health plans and the providers and our employer clients exactly who's doing well, and I think more importantly, who they're doing well for. So I'll take LARC as an example that does a digital version of the DPP using artificial intelligence and text messaging. That may not be wildly successful for everyone who might want to come to DPP, so you wouldn't want just one point solution, but they they do really, really well in people that pick that program because we allowed them to pick it, where they probably wouldn't do well at all in a Weight Watchers or something. So our ultimate goal, we started with DPP to prove the business model. We're integrating other programs. We're identifying problems for payers. What we have found is if we can solve a problem for a payer, they will pay us regardless of a CPT code, right? It doesn't matter. I mean, originally my product strategy guy said, you know, let's find a CPT code and we'll go out and then we'll have a revenue model. And you guys saw that with CCM, right? As soon as those CCM codes came out, everybody wanted to do chronic care management. The beauty is find a problem and purpose-build a business model to solve that problem, and the health plan will pay you. Somebody will pay you for it because you're solving a problem, and they can be pretty creative. But what we see our role is being that platform that allows digital therapeutics, telehealth platforms to get paid through medical claims without having to have a contract necessarily with the health plan or provider groups. Now we're in Johns Hopkins, UPMC, you know, quite a few integrated delivery networks that their physicians are referring into this. But how do we touch people throughout their life longitudinally as people need to plug into these programs to make them successful between episodes of clinical care? So that was a lot thrown at you in a very short period of time, and I'm happy to take some questions.
Hi, thank you for speaking. I think that this, I'm super excited to see that you're doing this. I think it's a really great idea because a lot of point solutions are not going to be the ones, almost by definition, the ones that are good at contracting and dealing with the insurance piece of this. I'm curious actually because you know, you do this combination of the digital therapeutic versus the in-persons, and I'm really interested because you know, I've seen data, very preliminary data on, and some of this is fairly intuitive, that some of the digital therapeutics have, it might be easier for someone to sign up, but by virtue of it being easier and lower commitment, there's maybe lower adherence or lower commitment through the program. And as someone who's building a digital therapeutic myself, I'm really curious, how much does that jive with the experience you've seen? And what have you seen that kind of avoids that or maybe addresses that issue?
Yeah, we definitely see that. I think people think it's easier. I'm going to do it on my phone. I have my phone. It's going to be easy. It actually takes a greater amount of personal accountability to do something on your phone. And we did see that where people would sign up and then they wouldn't have sustained engagement. So asking them things like, do you use email on your phone? Like asking them some other things about what they actually do on their phone. And then we actually started asking them some questions like, how likely are you to do this? And by asking a question that way, you were able to sort of get them thinking about, am I really going to log my food on my phone? Now, what I have seen for some of our partners is they've already integrated with Alexa. So Alexa in the morning will say, what did you have for breakfast? And it's a heck of a lot easier to tell Alexa, I had an egg and a piece of toast, and have that logged into the app as opposed to having to go in. So I think it's up to all of us to make the barrier to actually doing what we want people to do to be easier through some natural language processing. But asking them, how likely are you to do something, so they're thinking about how likely am I to do it, actually helps as opposed to just sending people into something that they think is easy that might not be. We do have about 5% of the people that switch.
So I have two questions. I mean, number one, great presentation.
Thank you.
I mean, like, this is where I see the Milton's vision and your vision gelling together. I mean, like, defining a goal, understanding a problem, and finding a root cause, and designing a solution, and push through. Amazing presentation. And basically, my question is, you're doing a great program with DPP, okay? And US healthcare, like I keep saying, it is a $3.2 trillion problem. And obesity itself is $1.3 trillion problem. And basically, obesity has to be the focus too. And my real question to you is, when do we get to that? And the second question is, what made you do all this?
Well, that's probably at the break, but I would say, you know, I'm definitely a go big or go home person, and if somebody says I can't do something, it says I just means I can't do it with you. So that's kind of my mantra. But I would say, you know, DPP, I'm disappointed that we even call it diabetes prevention, right? It's a cardiometabolic risk reduction obesity management program, and I asked the CDC, why do we call it DPP? And they said, well, I think because we can create a movement around prediabetes, and so I would like to get just talking about it as the gold standard for risk, weight loss. It's a phenomenal program. But I would say my biggest problem, Blue Shield California sends me their entire eligibility file. They send me 3.5 million names, and I outreach to folks and say, please join this program. We're not a brand, but what I'll tell you, I have 500,000 people in Colorado, and they didn't give me an eligibility file. I had 28 people enroll because physicians are not referring into the program. That's my biggest issue, is like, you see patients every day, and yet, send them our way. They're covered at 100%. There's no copay or deductible. So what I'm looking at next to kind of address that is, can we just set up, either with the California State Medical Association or nationally, a national enrollment site? I mean, we are already covered for almost 30% of the US population. So when you screen test, I would say you can't cross the last mile of referral because you don't know where to refer them. People send them to the CDC site. Well, it's A, incomplete, and B, there's no actually way to verify eligibility and enroll. So we're looking at kind of an in-kind, like, I don't care what you call it, but can we just set up a site where it makes it really easy for doctors to just go to Solera for me, they're going to find a home for you. That would be, I think, the last mile in what we're thinking about of how to solve physician referrals into these programs because they're not happening.
So, Brenda, thank you so much for that amazing talk there.